can record. Okay, so yeah, guest speaker event with Dr. Ashwin Reddy. He's going to be going over his personal experience in ophthalmology and his career journey. And then he'll be talking a little bit about his overseas work and then also a little bit of research he's done in retinoblastoma. But before we get started with that, I've done a little bit of research about Dr. Reddy, and I'll just be going over a little bit about what he has done in terms of his education and also his current role. So, Dr. Reddy specializes in children's eye health and retinoblastoma, which is childhood eye cancer. And he's currently working as a lead clinician for pediatric ophthalmology and retinoblastoma services at the Royal London Hospital. He is also an undergraduate lead, so he teaches as well for ophthalmology at Queen Mary University of London. And he is a honorary consultant at Moorfields Eye Hospital. And he is also chair of ophthalmology in the European Retinoblastoma Group. And he also has his medical degree from Cambridge and also Warwick, the School of Warwick. And he also has a research doctorate, which is also known as an MD. And so I'm guessing this is the research doctorate he did on retinoblastoma, but that's just a guess. He will confirm, hopefully. And he also has a specialist ophthalmology qualification, which is needed for a consultancy job in the UK. Is that right, Dr. Reddy?
Yeah, it was actually in cataract genetics, but we'll
Oh,
talk
okay.
about that. Yeah, but
Yeah.
it's in my talk, so I've got some
Yeah.
interesting stuff for you to listen to. I hope.
All right. Okay, we'll get started now.
Okay, well, thanks, guys. So Mufasia, it contacted me. I'm in charge of ophthalmology teaching at QMUL, and he asked if I could do a Sunday evening chat with you guys. And I'll try and make it pretty broad so A-level students and medical students will get an idea of what's going on. Um, in ophthalmology, it's quite a specialized area, so a lot of doctors don't know very much about it unless they've been taught well at their medical school. Okay, next, please. Okay, so why am I a pediatric ophthalmologist? So I like pediatrics and I liked ophthalmology, so I mixed it too. So this is for people, older medical students. So um, when I started 30 years ago, we didn't have shift systems. So can you imagine? We start on a Saturday morning, we work all Saturday night. This is if you're FY1 or 2. We carry on a Sunday morning. This is no, you might get an hour's sleep Sunday morning, then you carry on all Sunday night. Then you do Monday morning and you finish at Monday at 5 o'clock. Can you imagine that, Serena? So that was starting at Saturday at 9 a.m. and finishing on Monday at 4 p.m. So that's the era I come from, and how we used to work. So we didn't have shift system, we just worked like that. So I was interested in pediatrics, but they had quite an onerous on call, and obviously they were working 24, 48 hours at a stretch. So, so I combined pediatrics with ophthalmology. And why else would you be interested in ophthalmology? So it has medicine and surgery attached, and that's why you want aspiring surgeons. So it's a surgical specialty, but medicine's quite nice because it's more like detective work trying to find out what the condition is. And now with Generation Z, we like more a work-life balance. So I was ahead of the curve there. So ophthalmology has that. And that's why it's quite competitive to get into. That's why a lot of people contact me very early in their career to try and get into ophthalmology. But there's sometimes an assumption that it was easier before, but it's always been very difficult to get into ophthalmology. And it's also really interesting as well. I remember putting contact lenses in and thinking, wow, I can see. And that's one of the reasons I got into ophthalmology, and I really liked it as a specialty. Yeah, next. So it's a difficult specialty to enter. Probably a lot of people listening to hear some of them may want to be ophthalmologists, but it's quite tough. And that's why I quite like teaching because when you're in the nitty gritty of the NHS, it's quite nice to have the enthusiasm of medical students. And the awareness is actually a very difficult specialty to get into. When I was doing it in the night, trying to get in the 90s, we undertook 2 years. Some people would do 2 years of medicine before applying. So they get a degree in medicine, which was called MRCP in those days. There's something similar now. Um, and this is before we had the run through Calman um, registrars and so residents now. Nowadays, if you apply, you're there till the end. But in those days, you would try and apply, but it would be difficult to get into ophthalmology. And even when I was applying, I was told it's very difficult to get into, think of other things. And in those days, people used to do a PhD or an MD. So PhD and MD are similar. PhD is 3 years, whereas an MD is 2 years. The confusing thing about MD is in America, they're called their degrees, their medical degrees, MDs. But here, it's a 2 year research um, thesis essentially, and then you submit that and you do an oral, a viva, and you get through it. So it's quite it was very tough back in those days as well. So what I did was I realized it was going to be difficult, so I actually did some research and I did the part one before I applied for getting into ophthalmology. Yeah, carry on, Serena. So this is my first paper from 1995, for 30 years ago, which I dragged out for this talk. So I'm glad I was able to do this. And this is Bill Aylward. So it's a lot of people go to the consultants, but actually he was a registrar um, when I was um, when I was looking for research projects. So I was in Cambridge, and my registrar, the resident who was teaching me, was in general medicine, and she asked what I wanted to do, and I said ophthalmology. So she knew Bill, who was down in Moorfields. So I did. We used to have something called a demonstrator job, which you may not know, and with that job you learn anatomy. So for ophthalmology, you have to know your head and neck anatomy. So you taught medical students head and neck anatomy. And then when you taught them head and neck anatomy, obviously you're learning it and then you can take the exam. I was lucky enough to pass first time. I didn't pass all my exams first time. I passed that first time. And then I got this paper with Bill. So I thought I was all set, but it was very, very difficult to get in because it was catch 22. So people say, well, what experience have you got in ophthalmology? And if you didn't have any experience in ophthalmology, they wouldn't give you a job. So I was applying for teaching hospitals and it was very, very difficult to get in. I remember going to one job and the guy who got the job had a broken arm. So, it was really, and he wasn't going to start anytime soon. But it was very difficult for me at that stage to get into a job where you could actually do ophthalmology. But eventually, Cambridge took pity on me and they gave me a 6 month post. But Bill Aylward, this guy here, he became medical director of Moorfields. So, and I was fortunate to have known him when I was a registrar. So these things happen. And the thing is, when you're doing research, I have a lot of medical students ask me to do research, but you have also within that group some very excellent medical students who are really interested and show the deadlines and do everything, and then another group who aren't that interested, not that committed, and that's really hard work when you're a consultant working with them. Yeah, carry on. So this is for medical students who haven't done their ophthalmology bit yet. So and A-level students. So the subspecialties. So this is what I do: pediatric ophthalmology. Yeah, carry on. So that's obviously children under 16. Adnexal is around the eyelids. So this is a basal cell carcinoma. So this is actually cancer related as well. And that's another specialty. So consultants would specialize in each of these things, especially at Moorfields when we're very highly specialized. Yeah, carry on. Cornea. So if you put a contact lens on your cornea, you'll know what that is. And you can have specialists who do that. A lot of corneal specialists are refractive surgeons, and just treat adults with refractive surgery, which is, is their thing. So fair enough. They enjoy it. Carry on. Uveitis is inflammation in the eye. It's a very specific area, a very interesting area, and that's where sort of the detective work in medicine comes in. You have a condition in the eye, and then you make a diagnosis regarding their life or their um, what general systemic condition they have. So it's quite interesting. Yeah, carry on. Glaucoma is high pressure in the eye. So you have glaucoma specialists who just deal with glaucoma and nothing else. So they will do cataract surgery as well. A lot of these specialties will also do cataract surgery, and I'll come on to cataracts. Carry on. And vitreoretinal. So vitreoretinal is if you're short-sighted, which many of you will be, and you have a retinal detachment, it'll be a vitreoretinal surgery that's involved with that, a surgeon that's involved with that. Recently, you may know in the news there was something about a chip, electronic chip in the eye for age-related macular degeneration, and basically magnifying things so that people can see who are blind with dry age-related macular degeneration. So that was one of my friends at Moorfields who was partaking in that European study in UK. So vitreoretinal surgery, you'll often hear about that in the news. Carry on. And medical retina is not so much surgery, it's more injections in the eyes for age-related macular degeneration. So the good thing, and carry on. And we have other specialties as well. Neuro-ophthalmology, so that the brain affects things. So if you have wobbly eyes or brain tumors that can come into uh, that can be symptomatic in the eye. You have medical ophthalmology, which is more inflammation of the eye, a bit like uveitis with no surgery involved. You have primary care ophthalmology, which is more related to emergencies. So patients come in, with a red eye, and that'll be coming to primary care, or they'll lose vision. That'll be primary care. And ocular genetics. The good thing about pediatrics, which is what I do, most of the time, I also do retinoblastoma, is that it's a lot of everything. So when the child comes in, you don't know which one of these it's going to be. And that makes it broad and makes it very interesting, actually. So that's why I quite enjoy pediatric ophthalmology. Yeah, carry on.
Just a second, sorry.
That's all
Is
right.
that the right slide?
No, it's the next one now, Serena. So if you go back,
Yeah,
I think I've got videos. That's why
yeah.
it's taking me. So this is examination of a kid, of a baby. And what I have to do is look through a 4 millimeter gap. So in the iris, you've got a pupil, which is a black area, a void, and you have to look at the retina. You have to look through this tiny area, 4 or 5 millimeters, and have a. It's easy in an adult because they stay still, but in a baby, they'll move. Do you want to repeat that again, Serena? Um, they'll move around. So you've got to make noises, get their attention, get them on board. And that thing I'm using is called an indirect ophthalmoscope. But it is an art and it's not easy. And that's why a lot of people don't like doing pediatrics and pediatric ophthalmology, because examining children is hard and you're dealing with the parents. But I actually quite enjoy that. He's an 8-month-old, so with examination here. Yeah, carry on. The next one. There we go. Okay. And this is a 3-week-old, and I do a lot of work with premature babies called retinopathy of prematurity. So you're examining them like this. So it's quite different from examining adults um, in pediatric ophthalmology. And carry on. And I have my own stickers. So, if you read it, it says, Mr. Reddy says, well done. So I can give you all a sticker afterwards if you like. But this is really for the patients in my clinic. So it's a very different feel from an adult surgeon's work. Yeah, carry on. And hopefully the video will work at some stage. If you go back.
Yeah, I don't think it will play.
Okay. Go to the bottom of the slide, see if you can. If, no, okay, I don't think it'll play. But
Yeah.
anyway, there's just that's a child with a wobbly eye, and they're quite difficult to examine, but you can get them to see things, which is quite good. Okay, so I got into ophthalmology and I spent time in Cambridge, 6 months, and then this is before you had the run through. So I went round the country, which is really good. So you're seeing different people. So I did 3 years in Leicester, where I did my full fellowship, my part two and part my final fellowship there. And then I came back to Cambridge to finish off my residency. And there I met a guy called Tony Moore, who was a world expert on ocular genetics. And I found that really fascinating how genetics and pediatrics work together. And I did my research in inherited cataract genetics. So yeah, next one. And this is him. This is Tony Moore. He's retired now, and he was world expert on cataract genetics. Yeah, next. And what's cataract genetics? So basically, hopefully, some of you will know that cataract is the most common operation, and this is a surgeon's talk in the world. And because the blindness is eminently treatable. However, it can occur in kids as well, and we were looking for the genes in kids. Yeah, carry on. And I was identifying families and looking at genetic mutations. Yeah, carry on. And yes, some of the arrows are missing here, but never mind. But I'm looking at isolated autosomal dominant cataracts or inherited cataracts. Carry on. And again, the slide's gone for some reason. Okay, yeah, carry on. So this is a really interesting family. It's called the Wolsey cataract, and it was first spoken about in the 1980s. And this is an island where out of 1,000 members on the island, 100 people have a cataract. Carry on. And where is it? It's up in the Shetland Islands, right over there. Yeah, carry on. And in the Shetland Islands, we have an island called Walsey. And there you can see the arrow pointing to it there. So to get there, you have to fly in, you have to take a ferry, and then you drive across there. Carry on. And this is the ferry going there. And it's a beautiful place. There are no trees there. They have to import all their wood. And it's a very rich place because of oil at the time and fishing. Yeah, carry on. And I went with a consultant from Aberdeen who goes out there to examine patients as well. Carry on. And I had to examine them all and see what type of cataract they had. And anyway, that was a picture of the genealogy. Carry on. And they all had can you imagine this? All 100 had a cataract that looks like that. So that was due to one genetic mutation in that area, which is really interesting. Carry on. So this is where I work now, Whitechapel, which is one of the most deprived areas in the UK. It's a Royal London hospital. And it's quite good overseas work. So it gives you a flavour of, you have to, if you have an interest in different cultures, different peoples, and traveling, it's really interesting. Yeah, carry on. So what does it breed? It breeds resilience. It means that you're unfazed by changing circumstances. Like I was operating once and an earthquake going on. So you don't have that in England very often. So you learn about different cultures. You meet incredible doctors and nurses who do incredible work in very difficult circumstances. And you have experience in different countries. Yeah, carry on. So when I was a resident, I used to do a lot of cataracts, and so in the cataract era, carry on. Um, in many parts of the world, they'd only have a few eye surgeons, and so there'd be a great burden of cataract that weren't operated on. And this is a fellow I met, John Sanford Smith, who was a consultant in Leicester. I met him in Leicester, and he wrote a lot of um, books, well, several books on eye disease in hot climates because he'd worked in Pakistan. He'd worked in Pakistan for 7 years. He worked in Nigeria. He spoke fluent Urdu and Yoruba. And it was quite funny in Leicester because I speak a bit of Telugu, but no Hindi or Gujarati. And the elderly Gujarati men and women, they'd speak to me in Gujarati. I couldn't understand them, but he could speak to them because he knew Hindi and Urdu because he spent many years in Pakistan. And he was very involved with global ophthalmology and trying to improve care in low-income countries. So this is a picture in Burma. So it's a pariah state, and we were there about 2000. So it was the first overseas work I did doing cataract surgeries. Carry on. And we invited him to Barts. I'm going to invite him probably next year to Barts Ophthalmological Society again, because he's very interested. Carry on. In this, the arc light, and I'll talk a little bit about the arc light. It's this thing here that you put around your neck. I'll talk about that later on, and it's an ophthalmoscope and not otoscope. Carry on. So this is a young me as a resident, and we gave lectures and we operated on cataracts in a Buddhist temple, a Buddhist monastery area in Mandalay. Carry on. And there people would come hundreds of miles just for this operation. They come on boat, a train, bus, just to have surgery because when we arrived in that area, there weren't many surgeons around. So it was advertised in the newspapers and on the radio that we were there, and then people would come for us to do surgery. So this is 25 years ago. Nowadays, there are a lot more cataract surgeons around, but in those days there wasn't, and I was still a resident then. Carry on. And in those days, it wasn't day case. They'd have to wait in hospital for a while. And we had very committed nurses who'd operate with us. Carry on. So also around a year or so later, I was in, this is in Rajasthan. And the thing in India in those days was all the surgeons would stay in the big cities. They wouldn't go out in the rural areas. Yeah. And this is actually, so the last place was a Buddhist monastery. This is a Jain inspired hospital. Yeah, carry on. And this was with an organization called Second Sight, and they were sending eye surgeons to India in rural areas and for them to operate. But actually, I learnt then because the surgeons there were excellent, the Indian surgeons, and so they taught me what we call sutureless extracap surgery. So nowadays, if you do cataract, it's something called phacoemulsification. There's no stitches, but this is without that expensive machine where you can still operate and not have to put stitches in, and it's a lot quicker than putting stitches in. And you can see earthquake because at that time there was a war about to happen, 2001. Just for a change, there was a war happening or about to happen between India and Pakistan. It didn't actually materialize, and at the same time as potential war in 2001, there was an earthquake happening in that area as well. Luckily, it was just a tremor, but I remember operating and then just having this tremor there. Carry on. And this is Lucy Matton, who set it up. So she's Indian heritage, and even though she doesn't operate, she is an ophthalmologist and she gets surgeons out there. So now they're going more to Bihar or more backward states. A lot of states now, especially in the south and around, there are enough eye surgeons to look after the load. But there are some more backward states like Bihar where she gets UK surgeons involved. Carry on. So the next one. So then I went, so Buddhist monastery, Jain inspired. This is a Christian mission now. So this is in Malawi in 2003. Absolutely beautiful place and very rural at that time. Carry on. And this is where Malawi is. I've been there 4 times, all related to trying to promote um, eye health. And also, if you can see nearby Zimbabwe, which I've been to about 4 times as well. And you see Nigeria on the west coast as well. Okay, and go on. And so Nick Metcalf, I met him in Leicester, and he was very involved in um, having um, helping low-income countries to do eye work. So he was an ophthalmologist in Leicester, and he moved to this place near Lilongwe, the Nkomo mission, to do essentially do lots and lots of cataracts. Carry on. So there is a Doctor's African mission, and in the middle on the left, you can see in the color photo you see us in Leicester. Yeah, carry on. And this is really beautiful Malawi. So it was up a mountain where we were. Carry on. Then Como mission, and you have to watch out for the scorpions in the morning. Carry on. And so there was a great devoted team to do cataract surgery. Because I'd learned in India how to do this sutureless extracapsular capsular cataract technique, I introduced it to Nick, so he learned bits of it from me, and then he went to Nepal for the rest. Hi, Serena. I can't see the presentation.
Yeah, sorry, we're having a little bit of like a technical issue where we have like 5 minutes left until the meeting will end.
Oh, okay.
Yeah, so that's quite unexpected. Let me
Okay.
just share my screen again.
Okay.
Sorry about that.
I know Zoom is a bit like that sometimes.
Yeah,
They have a half-hour thing, don't they? That's why Teams is better sometimes for these
yeah.
sort of things.
All right.
Yeah, I think it says, yeah, I think it says 5 minutes. I'm gonna try to fix it on my end,
Okay.
but I'll see what I can do.
Yeah.
Yeah, I know Zoom can be a bit like that. Okay, we're going to restart, I suppose. Okay, carry on. And this is a team there. Carry on. And he's an amazing guy because he, um, at that time, a few years later, he was doing the most cataract operations in the whole continent of Africa, which is just amazing for one guy who was just on his own in this mission in Malawi. Carry on. And that's it. More beautiful pictures of Malawi on an autumnal day. Carry on. And sadly, he had a large stroke, so he stopped operating. But he's done incredible work. Carry on. So when I was in Malawi, I saw this kid who had both eyes retinoblastoma, which is a cancer that affects the eyes. I'll talk a little bit about it now. So what would have happened to this baby? Well, this baby most likely, what could we offer? We could only offer removal of the eyes then. And parents, when you mention that, they'll just run away. So the family ran away to the village, and probably this baby died. Yeah, carry on. And the great thing about having been here being around for 20 years is now things have improved. So more recently in Zimbabwe, if you carry on, we set up pediatric ophthalmology there and really emphasized it. Yeah. And now helped create an environment where the service was in accordance with World Health Organization rules regarding that. Carry on. And in Nigeria, there's great work going on. Carry on. So now we're moving on pediatric ophthalmology to retinoblastoma. This lady, Dupe, she is a good friend of mine, and she's really set up an excellent unit in Nigeria to treat kids with eye cancer, which is now what my interest is rather than cataracts. Carry on. And that's me teaching. Carry on. And they have a great environment where the nurses, they create a child-friendly environment, which is unbelievable, really. Carry on. And this is a goat's head, and you're teaching eye removal in that environment. So we have the COVID era. So I was doing a lot of traveling then, and in COVID era we're doing a lot less because of obviously COVID, and it's also better for the environment not to travel so much. Carry on. And now I do stuff with Médecins Sans Frontières, where they have children with eye conditions, and sometimes you can offer good advice. So they thought the baby on the right had a cancer, and they didn't. I just asked them to put a bit of tape on the eyelid, and then that swelling it was just a floppy eyelid, and it improved. So, but a lot of people I speak to who are on MSF, they are generalists, so they haven't been trained very in ophthalmology at all, so I can give them some advice regarding that. Carry on. So what is retinoblastoma? So it is a cancer, and in the UK, where I lead the service, we have a 99% survival rate. So it's the best type of kids cancer you could have. But in Malawi, which I talked about, it's better than it was, but it's still um, um, 50%. So it's about half that, which is really unfair. Do we have to come off and join again, or are we all right?
Yeah, just on this um, link, and then we can continue the presentation.
Okay,
Everyone,
so
just can you join on this one? I'm so sorry this happened. It wasn't really
shall I
planned.
leave?
Yeah, and then just join on this link that's in the
Is
chat.
it being emailed to me?
Yeah, I can email it to you. Yeah.
Yeah, because once yeah, okay, that'd be
All right.
better. Actually, let me see if I can do it through the chat.
Yeah, apologies everyone that this happened. It doesn't usually happen. Can you see it?
Let's have a look. I can see it. I'm going to try and open it. Join new meeting. Leave. Oh, I didn't show you this before because I don't know what happened there. Can you see the video now?
Yes, I can see it.
So here it's assessing the vision in a small baby. And you can see with my scarf, the baby's looking up, and you can distinctly see it. And this is only a 6-week-old. So you can use these elements, techniques to get vision in small babies. Quite cool, really. Okay, let's have a look at that. This is just showing you there's lots of types of cataracts in kids, and this is the ones that I was working on. This is a genealogy, a family tree. So if you're a medical student, you need to know how to write a family tree. Look how big this is. This is that family from Wolsey. Let's get a bit along here. So retinoblastoma, not many ophthalmologists know about it. And those that do ophthalmology around the world in retinoblastoma, we all know each other. So it's quite a small club, really. So, so anyway, it's not fair that in some countries these kids live and other countries they don't live. And so awareness is important. So this white thing in the eye is quite important. And this thing is an ophthalmoscope if you're an A-level student. And all medical students should try and buy an arc light. So why is that? It means that you can do this test, which is the reflex test. Now, previously, it was known as a red reflex test. So this is a red reflex on the left and the white reflex on the right. But actually, in non-white kids, it's not very red. It can be orangey or pale. So we're thinking we want to change the name of glow reflex because otherwise people think that their kids have cancer. Another cause of a white reflex is cataract, which we just mentioned. So you can do this test in adults and kids. So this is a thing you need to get. It's called an arc light. Had a child whose father was a pharmacist, and he had this arc light, and the medical student didn't have it, which is really bizarre. But what you can do, this is it, and you can put it around your neck. I always have mine around my neck when I'm working, And it's got a little loop as well on here. Loop is a magnifying glass, so you can use it for lots of different things. But for you medical students, it's really important because you can use it to do the reflex test and look at the back of the eye, whatever you're doing, whether you're in ED, whether you're in neurology, whether you're in neurosurgery, if you're pediatrics, you can do the reflex test. And it's also got an otoscope for ENT as well. So um, if you're interested in ophthalmology, you should be using it because it's a technique. Unless you practice it, you'll never be good at it. And this is what I did for my son. And you can see it's quite white, the reflexes here, isn't it? But it doesn't mean he's got cancer. It's just the appearance of the video. So what I did here was I put a video, sorry, my iPhone on the back of here to do that. So you can see how good you can get an image. And those medical students who are taking ophthalmology exams, when we look at the optic disc, we look at the three C's, the color, contour, and cup. And here you can see the optic disc with a cup there and nice contour and pink on the outside. And the cup is about 0.4. So there's a lot you can do with an ophthalmoscope. But guess what? If you never use it, it's always going to be difficult and you'll never be good at it. So if I think for everyone, you should use this. Now, my mentor, John Sanford Smith, he was very much involved with the creation of this because it's got solar panels on it, so it can be charged by sunshine. And even though it costs 50 quid here, it's subsidizing it being sent to Malawi and Ghana. Ghana have ordered thousands of these because for cataract and particularly for eye cancer, retinoblastoma, you need to get them in the system as early as possible. So trying to assess is very, very important. So lots of nurses are using this in low-income countries. And so rather than buying an ophthalmoscope where the money goes to a shareholder, this money you're spending is actually going towards charitable work. And this is again showing the white reflex, why it's important. Sadly, for this kid, it was too late, so I had to remove the eye. And I'll show you more pictures of that. So what is retinoblastoma? 1 in 13,000. We have about 15 new cases. This is the reflex that you're worried about, which is this one here, this one here. And this is the normal one. And you can see it's not very red. And that's why we are changing. We want to change things. So let's have a look here. And change the name from red reflex to glow reflex. And there's 2 centres in the UK, one in Birmingham, one in London. I lead the London one. And it's a genetic eye disease. So RB1 mutation responsible for all bilateral cases. That's in 2 eyes. And in Germany, I asked the medical students, this is in the exams, and RB1 mutation responsible for 14% of unilateral cases. So with genetics, we use a lot of genetics in our service. So if the father has a genetic change, we look at the child for that genetic change. And now we can do cell-free DNA analysis in a pregnant mother for that, which is quite cool. And the same here, if you've got during pregnancy, we can assess this rather than putting them under anesthetic and looking for tumors. So we're developing pre-implantation genetic diagnosis where we're at the 8-cell level, 1 cell is taken, and if there's no problems, implanted in mother. But because it's a cancer gene, after 3 years of age, it's still there. And so they can get soft tissue carcinoma, osteocarcinoma, sarcoma, and carcinoma. So this is the white reflex you need to remember if you're an A-level student or early medical student. Look for the white reflex. It can be cataract or it can be retinoblastoma in a baby or a child, young child. You can have different colors. You can have swelling. You can have something called a hypopion. And then we need to remove the eye as soon as possible. This is a clinical assessment, so only in the UK, when I started, there were only 4 consultants that could do this work. Now we've increased it to 6. So because of the clinical need of experience of doing this sort of work. And we use this, which is a snare. We take the eye out and then we rehabilitate the orbit, putting a ball in, then stitching up. And in order to get counseling and acceptance, you have to have a nice prosthesis. And this is a child with a problem with the right eye, but this is a few days after surgery. Look how good that is. And this is when the prosthesis is fully in and fully developed. And you can see how good that looks as well. So really impressive. We also give chemotherapy. It can be systemic or in the artery, ophthalmic artery. You can see that's going all the way up here and into the artery. So this is back to Malawi. So 20 years ago, there was really not much there in terms of retinoblastoma. But now it's on World Health Organization. One of their top 6 strategies now is related to in cancers is retinoblastoma, which is fantastic. So they're really telling everyone around the world the importance of retinoblastoma, because if you've got a high birth rate, you're going to have lots of kids with retinoblastoma. And in sub-Saharan Africa, that's a real concern because of the high birth rate that they have there. And so after 20 years, it's really rewarding to see that things are changing. And these are all my fellows around the world who've worked with me and come to my center, Pakistan, Lahore, Bandung. This is Malawi. It's from Zimbabwe. The one from Chile and one from Israel. My fellow from Israel was seeing retinoblastoma patients from Gaza before the massacre and the war happened. So they're all over doing stuff. So now we have an MDT system to save traveling. And this is my last slide now. So this is Darren Harris, who lost both his eyes before the age of 2 years. And he has bilateral retinoblastoma. And he's played football for England, the Paralympics team. And he's a motivational speaker. And he spoke at Bath Ophthalmological Society. So the patients actually give you a lot of resilience because you see what they've been through. So it puts everything into perspective. Okay, that's me done. Stop share. So I
Uh,
think you've got a few questions for me now,
yeah,
Serena. Is that
yeah, I do have some questions. If anyone in the audience also has questions, please just put them in the chat. We'll pause and then go over your question as well. Let me just share my screen so then we can show the questions. All right. Okay, so first question for me is what does a typical week look like balancing teaching, clinical, and administrative work? So just a little bit of insight about how your daily life is in terms of weekly as well.
Yeah, so what I do is what we have in the NHS is you have like seven half sessions, which is clinical. But one of those sessions you can use for teaching. So I'm involved with undergraduate teaching and clinical administration as well. So I have clinics, I have theatre. So I will have pediatric ophthalmology clinics. I will have operating theatres where I do squints on a Monday, alternate weeks. When I have on a Wednesday, I'll do retinoblastoma. And I do something called retinopathy of prematurity, which is on neonatal intensive care unit. And I also do undergraduate teaching. I also review papers. I also write papers, and usually I'm doing that in my spare time, that aspect of things. And I'm supervising medical students. I have some medical students that I'm supervising. Okay.
All right, thank you. Can I have Ahmed for this question? Oh, we
Would you
actually
like to
have a
continue with that
question.
already?
Yeah.
Sorry, would you like to continue with them?
Yeah, so we have a question from Ellie. Why are there so few surgeons in ophthalmology despite it being a very competitive field?
And so when I was talking about very few surgeons, I was saying in Malawi, when I arrived there, there were about six surgeons for a population of 12 million. So some countries have very few ophthalmology surgeons. That's what I was talking about. In the UK, so if you're in America, you do a three-year residency, and then they produce a consultant. So my residency was 11 years, and they've reduced it now to about 6 or 7 years. So it takes a long time in the UK to come out as an ophthalmologist, but it means you'll actually have comprehensive training, and you can basically see in everything. You're not phased by anything. Whereas obviously, if you reduce the training, you have more of them. They have they get more anxious about things they haven't really come across. So there's that element to a long training program. Now, what's the issue here in UK is there aren't many specialty places, and that's why it becomes very competitive as well. Um, if you look in the States, it's also incredibly competitive there as well, but they have more ophthalmologists as well. Okay.
It also could be due to a lack of resources in poorer income countries.
Yeah, so that's why I was talking about Malawi.
Yeah, yeah,
Yeah, rather than here. Yes.
yeah.
So basically, you need. So you're an A-level student, so you'll there'll be a lot of places for you to apply to for medicine, but in low-income countries there aren't many places for
Mm,
medicine, and within that you have ophthalmology. So that's not just for ophthalmology, but you have to be a doctor before you're an ophthalmologist.
yeah,
So
of course.
there's that aspect as well.
Yeah.
But that's the issue. I think if you look at anesthesia, obs and gynae in the NHS at the moment, it's there aren't many spots available really for specialist training. I think that's why not you guys, but all your senior colleagues are all striking in a few weeks' time, which means I have to do a whole heck of a lot more work.
All right, we have another question in the chat. How do you see AI shaping the field?
Yeah, it's something called age-related macular degeneration. So basically, it's called something called OCT and scans. It's very difficult if you're a medical student or an A-level student to sort of grasp that a little bit. But what what's happening is you diagnose things in the retina using imaging, and so artificial intelligence can speed things along in that. So we have a lot of medical retina consultants who do that. So instead of them diagnosing, AI can be involved with that. Also, if you've got, it can help in ocular genetic conditions. If you've got rare conditions, AI, Chat GPT is supposed to be PhD level. So if you feed it with information, then there's that can help. But I review papers, and some people just use Chat GPT to write papers, and it's a lot of rubbish coming out as well. So you always need somebody who knows what they're talking about in there as well.
Do you think AI, perhaps in like a couple years' time, would be a large part of the specialty as well? So ophthalmology?
Yes, because of that medical retina element.
Yeah. Another one, you mentioned working in backward countries where families didn't understand the importance of surgery, which
Yeah, I wouldn't
eventually,
say it's backward. I mentioned backward states.
yeah,
So Bihar is acknowledged to be a dysfunctional state.
yeah,
I didn't say backwards, so low income countries.
hmm,
When you mention resource, low income means there's low
yeah.
resource there as well. So what's the question?
Yeah, so low-income countries where families didn't understand the importance of surgery, which
Yeah,
eventually obviously leads to the child's conditioning worsening.
yeah.
What actions would you take to decrease the likelihood of this happening and help them understand?
So that's how we have counselling. So we have very good counselling in the UK. We still have some people. Many, recently they've been from Pakistan, but they can be from other countries as well in the UK, and they are very anti eyes being removed. So what we do is we have counseling, we have photos. I just showed you a picture of somebody who's had a enucleation, had a very nice result. So by showing those pictures and so forth, we try and get them on board. But sometimes we had a lady from Namibia. It's a cultural thing. It's really, really difficult to get through. And then sometimes we have to go to court about it as well. So this is in the UK. So you can imagine in those countries themselves, when we've got all our resource to help them, it's very, very difficult. But we try, and that's why we go to countries like Malawi. That's why we go to these countries like Zimbabwe to try and advise and try and help with the counseling.
All right, one more question in the chat. Do you think the surgical side of ophthalmology can be streamlined by AI, aside from the diagnostic and analytic side of things?
I don't think it's reached that level yet. I think it's going to take a while. It might be able
But
to do cataract. Yeah, um, I don't think it's reached that level yet. I don't think anyone. I will be hanging around for a while. I'd love it if they could just do all my enucleations and my laser and my cryotherapy for me, so I didn't have to do it. But they're not going to reach that stage until maybe you are a ophthalmologist for 20 years. Maybe it will have happened by your time, Serena, but not my time.
like there are a lot of like emerging robotic surgeries happening in like let's say neurosurgery. So do you think it could reach that level in ophthalmology one
I,
day,
I, I
hopefully
think it's possible, but not in the next few
soon?
years.
Yeah,
We've been talking about this for 30 years, actually. It's
yeah.
not a new thing. Um, so the thing about that robotic surgery is what they're trying to do is because they've got all these structures nearby and you can have a bit of tremor in your hands, you lose that tremor when you've
Mm.
got a robot going in there.
Yeah, so it's more precise.
So basically you're going in there and removing something, and then you'd be very accurate with 3D um, positioning of what you're doing. Now with cataract surgery, there's a lot of different steps that need to be done. You're not just going in there, you have to take it out, you have to put an IOL in and so forth. But I'm sure it'll be done. I remember the first intraocular lens that was put in, everyone thought that wouldn't work, but it did take some 1930 years for it to come through. So yeah, probably Serena, by the time you're a senior consultant, it'll be well there.
Yeah, hopefully.
Definitely there.
Can I hand over to Ahmed to do this question, please?
Yeah.
Good evening, Dr. Reddy. Thank you very much for presenting. It's been really insightful so far. So I wanted to ask you that as the chairperson of the European Retinoblastoma Group, what are the key challenges in coordination care across different countries?
Yeah, that's a good question. So um, what we have different groups within our European retinoblastoma group. Some looking at genetics, other people looking at neuroradiology, these areas. So what the challenge has been is to try and get everyone talking to each other more. And that's the whole point of this European retinoblastoma group is sharing best practice around Europe. And what we've instituted since then is trying to get each little group has its leads, is trying to get the leads talking to each other, so we're all heading in the same direction. And luckily, I have a colleague who's an oncologist in Germany, so it's working actually really well. But we have to meet up and we have to give deadlines to people. We think that if we give deadlines, then people start interacting more and then doing more outcomes that we're after for them.
Yeah, that makes sense. Thank you. So my next question was going to be, what's the most rewarding type of case you work on, or the most rewarding case you've worked on?
Yeah, I think if you these sometimes when you have a tiny baby with cancer in both eyes and you're having to remove one eye and then you see and they're only like 3 or 4 weeks of age and then you see them years later and they've got a tumor in the middle of their vision, they're walking around, they're achieving lots of things, going to, the older ones going to university, um, swimming for their county. That's really incredible, really. And I think that's the great thing in pediatrics, really, if you're hanging around there, because over 25, 20 years, you see these babies you've seen become adults. And I think it's really nice a subject.
Yeah, that's really nice to think about. Thank you. So I've got another question from Ismail. So he wanted to ask, are there any organizations or research groups in particular that are the forefront of AI technology advancements in ophthalmology?
Yeah, Pierce Keenan. So if you just do a bit of research, you'll find them. They're all it's happening at Moorfields with Google, and that's all that medical retina stuff I was telling you about.
Yeah.
Yeah,
Okay, thank you very much. So I'll hand over to Mufassir now. But thank you very much again, Doctor.
that's okay, Ahmed.
Hi, Dr. Reddy. Thank you
Hello,
so much
Professor.
for sharing your experience. I just have a few more questions. What skills or experiences for medical school have been most valuable in your career?
That's an interesting question. I think medical school. So I did a degree in anthropology. So in the first 2 years, I wasn't really interested in the science. I didn't enjoy the science element too much because at Cambridge, it was very badly taught. But when I did the clinical bit, I really enjoyed it. And when I did pediatrics, I really enjoyed it. And when I did ophthalmology, I really enjoyed it. So I joined it together to do pediatric ophthalmology. So um, that's probably the most I've got at the medical school in that it gave me, there were good special, it depends on your attachments really. So those attachments made a big difference to me into my subject that I ended up doing.
Did have another question. What do you think? Sorry, oh, wait, just get it up. Yeah. How do you handle the emotional challenges of working with seriously ill children and their families?
That's a good question. So we work as a team. And when I first came to the Royal London, it was all dysfunctional. I think that's why I was appointed really to try and help make the team more smooth. So we are very good nurses. So some of our nurses have worked with kids with brain tumors, and those kids don't do very well. So for them, even though for an ophthalmologist, most ophthalmologists don't want to have anything to do with cancer. For us, it's quite different from, say, doing cataract surgery. But for them, it's a different environment where it's less stressful for them. So if you work with that sort of team, and I've got good colleagues, Prof. Sagu and Mr. Zagretti. So if you work in a nice team, you can do anything. And that's the thing about um, just being a surgeon isn't adequate. You have to be able to collaborate and work with team members. You're a surgeon just doing your thing in the middle of nowhere, and you might be miserable and lonely. You have to have a nice team around you so you can deal. Every surgeon will have complications. They can deal with those complications, and you can work with colleagues properly. So it works.
Thank you so much. That's some really insightful answers.
I hope that's been useful for you guys.
Can I just have Mehvish to do a couple more questions, please?
Okay, yeah, go for it. Go for it.
Sorry.
Okay, thank you for sharing your experience. This one, right? How, okay. What are the biggest advances in retinoblastoma treatments you've seen during your career?
So we used to take out a lot of eyes. So in the 1990s, we used to take out 80%. Every child comes in, we should take an eye out in 80%. And now it's about 35%. So we reduced it right down, which is a great thing for families and parents. But it's hard work because if you don't take the eye out and the tumor spreads, then the kid can die. So it's a tight balance you're on. But that's what we're seeing now. And the other thing is, before we never do a biopsy, but now we're starting to think about biopsies in a safe way.
Okay, thank you.
That's okay.
Okay, last question I have for you. If you were to make a quote, what would you say? So anything inspirational, just to end this session.
Um, I would say listen to your patients because they often have the most important questions that need answering. And a lot of my research has been based on patients' questions.
All right, thank you so much, Dr. Reddy. Sorry for the technical problems. And yeah, thank you for those who stuck behind. If there's no problem, can I leave your email address in the like community page that I have, just in case people have any other questions that they would like to ask?
Yes, okay. So that's just within your group, is that
Yeah,
right?
yeah, yeah.
Yeah,
Just
as
the
you can
people that
imagine, I get
attended.
a lot of emails.
Yeah, yeah,
Being a lead, an undergraduate lead, and
yeah.
things
I can
like that.
imagine.
It's not, and also having thousands of patients under my care.
Yeah,
So, yeah, so I'll leave that with you, Serena. Okay.
yeah. Thank you so much.
Okay.
Uh,
Actually, what might be best, Serena, if they contact you and then
yeah.
you email me.
All right, I could do
All
that. Yeah,
right. That I
yeah.
think that'd be more appropriate. It's just that I have quite a lot on my plate generally.
All right.
Okay. Okay
Uh,
then. Thank you.
yeah. No problem. Thank you so much.
Hope it's been useful. Take care. Bye.
Thank you. Bye.
Bye.